There's no other venue than Goa. Goa is Goa. You can have North Goa, you can have South Goa.
That's not the rule. That can only be the change.
You should go with that was very ideal.
But the timing was not good.
Somewhere else. We were staying somewhere else.
But Goa is Goa.
And then the second day is total we are on the sea.
So what are the tentative dates now? We are planning, I need help in September, but I will start planning it from February. Get together. There will be only hardly 30 people coming. One day, right?
I know them because I was doing events.
कितना हॉल क्या?
That's nice. And all time on the
Morning. Yeah, it's on. Yeah,
Hello. Very good morning to all the delegates. We are going to start in next 3 minutes. As you have seen, Jim is ready. Anyone waiting outside the hall and who can hear us, please come into the hall and take your seats. Good morning. Today is an action-packed day from classroom to actual theater.
DY Patil, you are ready with the case?
So 1 second. No, we have chairpersons are different. We'll start. We'll start.
Communication, right? We'll connect first.
Yeah, please correct. Because it will get delayed again. You want to go there? You can.
Comfortable.
So you are the chairperson.
Can we connect to Dr. Patsardi, please?
Hello.
Sir,
Yeah.
I would like to welcome you from Kolhapur, sir.
Hello.
Yes, sir.
Good morning,
Good morning.
sir.
Good morning, sir. Good morning.
Yeah, I'm Dr. Hoshing speaking, and we are delighted you are joining us, and we would be all are excited to see your surgery.
Welcome to Mexico.
Yeah, thank you.
With me is Dr. Ravindra Bhate from Gokak.
Okay. Thank you. First, I like to thank the organizing team of Masikan 2025 Kolhapur to giving me this opportunity, and thanks to the moderator. Today we are planning for two cases. One is a TEP that is called nowadays we called Palnivelu tip, P tip. Since E tip is famous, getting famous for popular for groin hernia repair. So we are doing this one from the beginning. So we are calling now it is as a P tip. I'm going to show you a P tip how to do for inguinal hernia and what are the advantage of P tip rather than E tip, and I'm going to show in a live surgery. Before going for live, you can have a history. Pasupati, make a history.
Yeah, please let's have the history of the patient.
Patient, yeah.
So this is a 88-year-old gentleman with right groin swelling, with no history of constipation, fever, or vomiting. And any particular investigations were done in this case?
Audio கேட்கல bro. Next slide, Matt.
The case history is as follows. 88-year-old gentleman who presented with complaints of swelling in the right groin since 2 months. It was associated with dragging type of pain, intermittent in nature, and it was relieved on lying down. There was no history of constipation, vomiting, chronic cough, or lower urinary tract symptoms. Next slide. On examination, abdomen was soft and non-tender. On groin examination, there was cough impulse present in the right groin and a reducible swelling, and a diagnosis of right inguinal hernia was made. There was also cough impulse present in the left inguinal region. External genitalia were normal on exam. Next slide. And we did an ultrasound abdomen and pelvis of the patient, and it showed bilateral inguinal hernia. So we planned bilateral TEP in this patient. Next. So our operating team is headed by Dr. Partha Sarthi sir. Camera surgeon is Dr. Dinesh. Anesthetist is Dr. Prabhakaran. Scrub nurses are Subbalakshmi and Sandhya. And our anesthetist staff is Sabita and Sumati.
Okay.
Partha sir, if you can brief us with the technique of P-TEC.
Yeah. Are you getting my view now? Patient abdomen view?
Yes.
Yeah. So this is the umbilicus, and that 3 centimeter umbilicus I just make arcuate line here, arcuate line, and this is the symphysis pubis. Okay. And you can see this is the bone, symphysis pubis, and I feel the anterosuppiliac spine here, left side, and then this is the right anterosuppiliac spine. Okay. So this everybody feel that it is very short distance. So big hernia is here, 2 hernias, so very difficult to put. That is a surgeon's mind. So that is if you place the port in the midline, so it looks very short distance. And if you place the port on above the level of arcuate line, camera, and on either side working port, then it will be, you will get a long distance. So just I'm going to show now, and I made an incision, and you can see here the incision is already made around starting from the midpoint of the umbilicus. You can see here it's a midpoint of the umbilicus. I made it around 11 incision, and I'm dissecting the subcutaneous tissue. And Palnivelu sir designed this retractor. It is a little modification of the Langenberg retractor. The tip is very slightly curved. It's not very much projected, and this is longer than the Langenberg, and it is very strong, very strong. So with this retractor, we can go even a patient is big abdomen, this one subcutaneous fat is there. For a central obese patient, we can go with this retractor. So I'm dissecting in the midline.
Sir, does it
And
make any difference?
my aim is to yes sir. What is the question?
Sir, does it make any difference if it's a direct or an indirect hernia?
No difference, no difference. And the indirect hernia, our preference is we can take the sac out. Now you can see the anterectus is exposed. Can you see this anterectus sheath?
Yes, yes.
And it is not in the midline. This is right of the midline. I exposed the anterectus sheath right of the midline, and I made a small nick. I don't make a very big nick. You can see small nick is made. If you make it deep, big incision, you will injure the muscle. So now I separate the anterectus sheath. Now I widen the incision with the artery forceps. Now you can see this muscle.
Yeah.
What you are seeing down is the muscle.
So
So now,
is the incision on the same side of the hernia, or it is always on the right side?
no, it is usually on the same side of the hernia. And if it is a bilateral hernia, then I will go for a right side. So now that is the muscle is there. So I want to make the muscle, retract the muscle from the midline. So I'm not retracting here. I'm coming here, and then I introduce my instrument little down to the muscle, and then I take this retractor up.
So the function of this retractor is mainly to go to the right side.
Yeah, to retract the muscle basically.
Okay.
Initially to retract the subcutaneous fat, and then retract the muscle.
And the
So
aim
now
is
you
to go into the retrorectus space.
Yes. So can you appreciate the retrorectus space now? This is the postrectus sheath.
Yeah.
This is the divided end of anterectus. Muscle is retracted. Can you see now the instrument is going freely now?
Yes.
Yeah. So now I'm taking the trocar without only the cannula. There is no operator without only the cannula.
So do you encounter any particular blood vessel here near the umbilicus?
Yeah, sometimes no branches from epigastric will be there. That is not all cases. Some cases it will be there. Will coagulate when you are going inside. So now you can see the trocar tip is inside the retrorectus space. There is no hold on the trocar, so that it will be slip when you are moving the camera. So I want to fix the trocar. That is the one purpose. Main purpose is why I am taking this suture. That is the main purpose, no slippage of movement of the trocar to be prevented. Second purpose is gas leakage to be prevented. So I take a stitch, and you can see I'm introduced you can see the trocar, suture, and the skin. So I'm introducing the gauze, rolled gauze piece between the suture and the subcutaneous tissue. If we keep it between the trocar and the
gauze piece is between the suture and the skin.
Skin, yeah. If you keep it between the suture and the trocar, then it will be slipped.
Okay.
So I packed it. How much space you created in the subcutaneous space, you have to pack it, and then I'm tying it. So the main purpose of the this gauze piece package is to prevent the movement of the trocar when you are moving the camera scope, and then second thing is prevent the gas leak. In ETEP, we are going direct entry with the OptiView trocar, or some surgeon they are going with the open technique. Here also same open technique in the retrorectus plane, and then the same thread is being tied around the side channel of the trocar. This is the one silk.
Sir, have you tried the Hassan's cannula to prevent air leakage?
No, sir, not even a single case. And this will be given a better result because the this one, it will not go in also.
Oh.
Hassan's will prevent to come out, but here it will not go in. Gas on, my assistant.
Partha,
So
sir?
now I close the trocar, and you can see I'm pulling. You can see how much hold it is there from the
Yes,
suture. Okay.
Sir,
Yes, sir.
do you do ETEP in any cases?
Yeah, ETEP for groin is for a very giant hernias and up to the thigh or knee, and then that case I will go. Most of the cases, 95-98% of our cases we can manage with the this one PTEP, pulmonary tip technique.
Okay.
Sir, even if the space between the umbilicus and the
Yeah, that is our preference is PTEP only. And some patients have a scar, midline scar or appendicectomy scar. Again, our preference is PTEP only. So now I introduce the camera inside, and I close the gas. Gas is not yet open so far. I focused it. Now I switch on the gas.
So can you just give us a briefing as to how it varies from a normal TEP, PTEP, just to
Now,
orient us?
yeah, it is a triangulation port. Usually we used to call it's a triangulation port technique.
Okay.
And initially midline port is the famous one initially, and people will find difficult with the midline port. Then they moved on to this ETEP. But here from the beginning we are keeping this port in a triangulation. That is a two-hand technique, no, otherwise called two-hand technique. On either side of the camera, the working port will be there. So nowadays we are calling it as a PTEP. So now you can see a gas will create this plane. This is fascia down, the above is the muscle. If I go here, that is the wrong plane. That is the wrong plane. You should not go here. The muscle should covered with some fat or some tissue. So you can see I'm going little down. So I'm going down.
In between the two layers of the fascia transverse.
Yeah.
Right. Dr. Pansari, we'll keep watching you and we'll just move on audio to the other hospital and come back.
Okay. Okay. Okay.
Thank you very much.
Okay.
We are now live with D.Y. Patel. Can you please go ahead to the case history?
Hello, good morning.
Good
Yeah,
morning.
please go on, sir.
There is a 37-year gentleman with complaints of pain in epigastric region since 8 days. The patient underwent ERCP with CBD stenting performed 3 months back. And on examination, abdomen is soft and no tenderness or palpation. And MRCP is suggestive of optimally distended gallbladder with multiple calculated gallbladder lumen, dilated cystic duct with 13 to 7 mm calculated. And the CBD is 5.7 mm diameter and stent institute. And let's have this case for laparoscopic cholecystectomy with ICG. Thank you.
Prasad sir, your mic on sir.
Yeah, this is a young gentleman, 37, 37 years old male patient. With history of CBD stones as well as cholelithiasis. ERCP was done in November, and now he has been posted for gallbladder surgery, cholecystectomy. We are using 1788 camera system by Striker and the RB system for dissection. This is the RB system. I will show you. Dr. Nirmal Patle sir is assisting me. And this is RB Trisect Rapid. This is the energy source which I am using. I will tell you, this is the coagulation. This particular mode is for coagulation, and this is for bipolar with cutting.
Really?
So this is different level of energy source, which is to be used in this particular surgery. And 1788, as now everybody knows, it is having the ANV mode and CSF mode. CSF mode, the utility of the CSF mode, we will see how it will be useful in difficult gallbladder surgery.
Rate sir,
Yes.
good morning. This is Dr. Hoshing. Moderators are Dr. Ravindra Bhate sir, Dr. Taukari, Dr. Sarmaik. We are very delighted to see you. So we just wanted to ask that the ERCP was done in November.
Yeah.
So before surgery, would like to do any investigations to see whether there are any the stent? Yes, residual.
Yeah, stent is still there, and there are no residual stones. And now the gallbladder, as per the PG 18 classification or criteria, that is Tokyo grading of the cholecystectomy. The grading Kellogg's difficulty is around 5. That means it is frozen Kellogg's. and therefore we are using all this technology to deal with it. My try will be to go to the cystic duct, because cystic duct is slightly dilated, and that means there can be a mirigine there. So how to deal with that mirigine, whether I will have to open the CBD or not, let us see. And we are waiting for the insufflator to start. There is some problem with the insufflator. The system is by Stryker. So you can, meanwhile, you can go to the other operation theaters.
Okay.
Yeah, can we shift
Right,
to jump?
Dr. Thank you very much. Back to Dr. Patsardi.
Yeah.
So I made a trocar, right side trocar. So this patient had a very short distance. So I particularly selected this case today. You can see I made a right hand trocar and I started going down. And you can use a scissor, hook, or a Maryland dissector. And scissor is my preference.
So
One of my favorite
right hand trocar is also in the right rectus box.
right rectus, yeah.
Yeah. And
And some patients I could able to go well distance, that is a linear seminoris line on the right side. And some patients epigastric vessel will be thick and multiple branch, so I cannot go up to the laterally. But sometimes I come medial to the epigastric. Most of the time I aim for a lateral to the epigastric vessel, my right hand, both trocar, right hand and left hand.
Sir, can you please show the external view once?
Yeah.
The trocars.
so
Can you see here?
Yeah.
Yeah.
And another trocar I'm planning here.
Okay.
So they will be in the same level as the umbilicus.
Almost same level or 1 centimeter down from the umbilicus.
No. So about
And now I have only one hand. If you see the external view, I'm holding my left hand camera with my left hand, and I'm doing it now. My right hand is dissecting because I have only one hand. Till I put the other hand, we have to operate with a single hand only. So I'm going down now towards the symphysis, and can you see this bone here? So that is the bone, symphysis pubis.
So do you divide the arcuate line in this procedure, or like each?
No, I don't touch the arcuate line.
Okay.
All my trocar is above the level of arcuate line. I don't touch. I don't divide. Basically, I don't divide. So can you see this left ramus and then this is the right ramus?
Sir, which is the camera system you are using?
So I'm using a Stores 4K. Spice 4K. It is not Rubina, it is Spice 4K. How is the vision?
Yeah, it's very good.
Yeah, okay. So now I'm crossing the midline. When you are if you want to cross the midline, all patients had a midline fat. My preference is going through the fat. If you go above the fat, you will be more superficial. And if you go below the fat, you will be very close to the peritoneum. And sometimes you injure the peritoneum when you are crossing it. So I'm going between the midline, middle of the fascia, so that I can able. Now you can see I enter the left side.
Yeah.
And
there looks like a hernia.
Yeah, it is a bilateral hernia.
Okay.
And if you see the loose areolar tissue, that means you are in the right plane.
So do you prefer to do the lateral dissection before tackling the hernial sac?
No, I do the lateral dissection means this is the epigastric vessel. I don't dissect here.
Okay.
I go up till I put the placement of my left hand trocar.
Okay.
I dissect the space, extraperitoneal space on the left side. That's all. I don't dissect the hernia side.
Hernial sac.
And some cases, I have done small direct hernia cases. I have done with a single hand. Single hand means camera and only right hand. I do dissection, entire dissection. I do the parietalization, and then I keep the mace. I fix the mace. So everything done in a single hand. So that is different, but that is not a routine practice.
It's really great to see you doing it with one hand and you have not put the second foot.
As yet.
Yeah, that's really.
That is the peritoneum. That is the lateral wall. I reach the lateral wall. This is the inguinal region. This is the lateral wall I reached. I want to make this trocar above the level of the arcuate line, almost at the umbilicus level line. I want to make a trocar. So I'm just dissecting here.
So this trocar you'll be lateral to the linea?
Lateral to the, no. It's a medial to the linea semilunularis line,
Okay.
and lateral to the epigastric.
Epigastric.
Yeah.
So about 5 centimeters from the midline.
Yeah. And I'm just checking whether it's possible to introduce the trocar. I have to dissect some more. So now you can see only monopolar scissor. That is enough.
So with bilateral hernia, the port position will be the same?
Yeah, same only. This is the bilateral only I'm doing for this case. Old man, direct hernia. So I think bilateral is good. I have 2-3 hernias today, but I selected this case because of short distance, and I'll expect a little bit difficult. So just I want to show you this difficult case live, so that the P-tape will be appreciated. Can you see this arcuate line here?
Yes.
So that is the arcuate line, and I reach the lateral level. So I'm placing my port now.
So just for the beginners, if suppose accidentally puncture the peritoneum, then what will be your plan?
Yeah, then if it is a pneumoperitoneum develop, that also happens sometimes. If it is a pneumoperitoneum, place the trocar, 3 millimeter trocar or 5 millimeter. If you don't available, you can make it a 5 millimeter trocar. That is on the right subcostal level, right hypochondrium level, so that you can make, you can release the gas. And after the surgery, you can proceed the surgery. You can continue with TEP. At the end of after that, I make a 5 mm scope inside, and then I'll see any trocar injury, because that is a blind trocar. So I want to see it inside.
So, but the usual teaching is to put in the palmus point, no?
That is a palmus only. That is the only I'm telling.
And also, most probably, they usually use a Viris needle rather than.
3 mm is a little bit better, so that amount of gas will go, more gas we can make it let out.
So if we put a port, then manually you have to release the gas every time.
You can keep it open.
Yeah, you can open this one, no?
Or you keep it open constantly.
Yeah. Okay.
So can we have the external view?
Yeah. I'm doing it. I'm showing it now. Clean. Are you getting now? Are you seeing now? This case, this is at the level of umbilicus I get able to made it. This is little 1 centimeter down from this one.
So this left hand port is away, is still in the rectus box or lateral to that?
Yeah, it is this one.
The left hand port?
Yeah, this is the camera port. Camera port. This is the right hand. This is the left hand. Left hand is little down from the umbilicus, but above the level of arcuate line. And you can see this is the tape I'm making. I just starting from this camera working port, and you can see it is a 15 centimeter here. And sometimes I'll get around 18 centimeter distance. And this case, it is again 15. See, this line is 15 centimeter. Again, this line 15. And if I go here up to here, this inguinal end of the inguinal region level, I will get another 3-4 centimeter extra. So I'll show you during when you are doing inside. Clean manicam.
Sir, the port position is the same in obese patient?
Same in all case. All case we can able to make this port position.
Right. Dr. Pansari, we'll just quickly move over to Dr. Rate and come back, sir.
Yes.
Thank you, sir. Dr. Rate? Yes, sir, you are.
Clean பண்ணிக்கடா. Clean இருக்கா? Focus இல்லாம இருக்கு.
Yes, Dr. Prashant. come on.
See, I have gone inside and you can see the various port positions. See, the patient is having a pendulous abdomen. Here is the pubic this xiphoid process here. Okay. And the distance between the umbilicus and the xiphoid is too long. So that is pineal signs, pendulous abdomen, umbilicus too low. Therefore, I have taken the supraumbilical cord at least 3 fingers above so that I can reach up to the calots. Otherwise, there will be a tangential view at the calots and it will be very difficult to identify the structures and we might miss something. Cool. Secondly, after going inside, I saw that you are getting the inner view.
Yes.
See, this is the fatty liver and there are some cirrhotic changes.
Yes.
And you can see above here, this particular is the costal arch. The liver is almost intrathoracic. Costal arch will be a hindrance for your movement of the hand instruments. Therefore, I have taken this particular left-hand instrument port, slightly above, just at the level of the costal arch, so that the instrument will not be getting hindrance while moving.
Dr. Aditya Anand here. Can you ask the company people to increase the light of the laparoscopy, sir? A little brighter.
Power. Somebody has shut off the lights of the camera system.
Wow. Okay.
So you can move to the other.
Right, sir. We'll get back to you, sir. Back to Dr. Parsardi, please.
Hello.
We are with you now.
Yeah. This is a small direct weakness here. This fat I reduced, and then this is the epigastric. I'm going for a space of Bowgrass. So I dissected. I entered the space of Bowgrass, and so this is the peritoneum, and not much fat on the triangle of pain area. This is the triangle of pain area. I'll show you at the end of the dissection. And this fascia is called Dulux fascia. So I'm just dividing it. It contains one vessel. Once you divide the Dulux fascia, then we can go lateral dissection well. So again, peritoneum edge is here. I'm dividing here. And some fat to be covered the triangle of pain area. A triangle of pain area to be covered with the fat. You should not go with this plane, muscle plane. You should not go close to the muscle. So this is the ideal plane. And I'm pushing now. And up to the arcuate line, I can able to dissect with this port. Since it is a triangle, two-hand, on either side camera is there. Your working movement and then range of movement is more than the midline port.
This is a 30-degree scope you are using, no?
0 degree, sir.
0 degree.
0 degree. 0 degree I use for initial dissection. I'm continuing with the same 0 degree scope. External view cut, camera cut. Camera cut external view. Yeah, camera nalla pidichukku light thiruppu. See, when I'm moving light cable vision is not moving. Go close. So always you can see, my hand is taking the tissue away from the main vessel. Should not, without traction, you should not coagulate anything or you could not cut anything. No, cautery will go to the main vessel. That is the external iliac vein. This is the vast difference. This is the peritoneum. So I'm just taking the peritoneum down. I don't want to divide any vessel. So I'm pushing down all the vessel as much as possible. You can see vas is covered by the tissue. You cannot see the vas very much badly. That means it is covered with the tissue. Can you close up? So yeah, covering one layer is there. Can you see this layer? Yeah, come out.
So we are a little confused regarding the left-hand port position. Is it outside the linea semilunaris?
This case, I can say exactly at the level of linear semularis level.
Okay.
Yeah. Sometimes I'll come medial to the linear semularis, lateral to the epigastric vessel. That's all.
Okay.
Our aim is to place this port lateral to the epigastric vessel.
So if we put that port down, do we have problems in placing the mesh? Superior?
No. It is above the arcuate line is there, no?
Yeah. Okay.
I'll show you when mesh placement.
Okay.
I'll show you how to play. You can see, no, all these small vessel I'm just taking on the patient side, triangle of pain area. So only the peritoneum I want to divide. I want to separate.
So what criteria do you decide to say that there is adequate peritoneal mobilization? When do you start?
Yeah, from here it is around 7 centimeter, because I'm going to keep mesh 6 centimeter, 12 centimeter height of mesh. So 6 centimeter down I have to dissect. So I'm planning for 7 centimeter distance.
So what is the advantage of putting the mesh at the umbilical level bilaterally, then putting it in the midline?
I'm not putting it in umbilical level. So it will come up to the arcuate level, upper border of mesh.
So what is
Camera is
the
in the umbilicus.
What is the advantage of it over putting all the ports in the midline? Some people put it in all the ports in the midline.
Yeah, midline port, no, they find difficult in dissecting laterally. Midline, that's why they are placing a port in the midline. So midline port exposure is very less, and you cannot put the mesh, large mesh, and movement of the trocar, movement of the instruments also will be difficult. Suturing is very difficult. Here, what I did, so the external view, lap open external view, give the external camera. So you can see my port is my port is, you can see here, from the umbilicus, I'm dissecting so much, so much just below the umbilicus, I dissecting so much, I'm going down. So that even a short distance, I can go laterally anywhere. If it is a midline port, my port is here, so very less space to dissect. Since my port is above, I can dissect down well. In E-tape, they are making the port little above the level of umbilicus, but the mesh is same mesh they are using it. So what our preference is, no need to dissect more, no need to divide the PRS, posterior layer of posterior rectus sheath for treating the inguinal hernia. That is a concern.
Sir, this port position will also help you in suturing, like it will be easy.
Yes. Our preference is suture. That's why I told, when I do single hand surgery, that also I sutured. I don't use a taker. So any case we can able to suture nicely, and some cases we very large hernia. This case also I'm going to show the plication of the pseudosac. Pseudosac can be plicated well because suturing is very much easier with the two-hand technique. Can you see that layer to be followed? You can see the uniformity of the layer, and it's not going deep or superficial. And if you keep this, there will not be any bleeding. You can see how much I dissected. This is the internal ring. You can see.
Yes.
Can you see this? Yeah. So more than 12 centimeter mesh we can able to keep, and some of the obese space, large hernia, same port I can keep around 19 by 13 or 14. Big mesh I can able. I take a 20-15 mesh, I cut, and then I can take. These are all the bowel. Below is the bowel. You have to be careful. And you can see the vas is here, and all the blood supply is preserved. Even in a young patients, we can do this procedure very much safely. And how much dissection, peritoneal dissection you want, parietalization, you can see vas is turning down. At that time, you can able to see the vessel, that is the obliterated umbilical artery. Can you see these arteries are here?
Yes.
This is the artery, vas is going below. So up to that level, we have to dissect. If we dissect further dissection, it will produce bladder injury. So that's why we have to avoid that area. So I think the left side dissection is over. I'm going for a right side.
So before you go to the right side, there are a lot of PGs sitting over here. Can you explain the anatomy?
Yeah, anatomy. Yeah, okay. So now this is the midline, and this is the symphysis port, symphysis pubis. Camera outer. Symphysis pubis, left ramus, and then you can see the rectus muscle, left rectus muscle, inferior epigastric vessel, and here you can see this line, white color line. that is the iliopubic tract, nothing but the reflected fibers of the transversalis fascia. It is presented deep. Exactly the superficial structure is the inguinal ligament, that is the reflected fibers of external oblique aponeurosis. The same level iliopubic tract is coming, and then it is going here. It's go below the cord structures, above the epigastric vessel, and attached as the Cooper's ligament. Can you see this is coming here? Can you see this ligament here?
Yes, sir.
Yeah, that is one. And
Like-
here it is like a fan-shaped, Y-shaped manner. And you can see this is the bone. I'm touching the bone. You cannot see, nothing is moving. Can you see here some structure is moving?
Yes.
So that is the Cooper's ligament. And so iliopubic tract, inguinal ligament we cannot see laparoscopically. That is a superficial structure. Same level, parallel structure, deep is the iliopubic tract. You can see this is the iliopubic tract. It is coming like this. And coming to the anatomy triangle, you can see this is the vast difference. And I'm preserving all the vessel. You can see all the vessel nicely. And I'm not dissecting posterior to the vast dissection is no need. And this is the vast difference. This is the gonadal vessel. And this is the triangle of doom. Triangle of doom, the boundaries is medially vast difference, laterally gonadal vessel, inferiorly reflected edge of peritoneum. And what structure you are seeing here, this is the external iliac vein, this is the external iliac artery, this is the artery, this is the vein, and this is the iliopsoas muscle. Can you see I'm dissecting? So this is the iliopsoas muscle. Even though it is called triangle of doom or vascular triangle, some patients we can able to see nerves here. One nerve is going in this vascular triangle, that is called genital branch of genitofemoral nerve. We cannot see in all patients. It will be below this fascia. And coming laterally, iliopubic tract is the superior border. Medial border is the gonadal vessel. Inferiorly reflected is the peritoneum. So this is called triangle of pain. This is called triangle of pain. It is covered with the fat. I preserve this fat. And if you dissect here, you will able to see the nerves. I don't want to open this fascia, and nerves will be here. Lateral cutaneous nerve of thigh, and the other nerves will be here.
Yes.
So what
And
about the
coming here, medially, it is called triangle of pain, triangle of doom. And this is the femoral canal. Femoral canal. The femoral canal you can see here. Femoral canal. Sometimes femoral hernia is there. It will go bowel or omentum will go here. We'll take this bowel. And femoral canal, you can boundary is superiorly iliopubic tract, medially pubic bone, laterally femoral vein. So this is the femoral canal. Iliopubic tract, pubic bone medially, femoral vein laterally. So this is the femoral canal.
So what about the obturator foramina?
Yeah, obturator is here. Go camera pidichuka. Usually we don't go up to the obturator. Our aim is to see the bone. If you see the bone, inferior margin of the bone is enough, obturator will be here. And old age, direct hernia, I think sometimes you can test this, check this obturator.
Yes,
Can you see this
now
obturator?
can be seen.
Yeah. And any fat or anything is there, you can take it out. And usually bipolar cautery is good because some small vessels might bleed. And you can see, thanks to the moderator, you can see obturator hernia is also there. I take out the small obturator hernia. I take out the fat. This much is coming, another fat. These are all the nerve and vessel.
So usually there would be some fat in the obturator. It would be empty always. There would be some fat protruding inside.
Yeah, this case is there. Some of the direct hernia, bilateral direct hernia patient, it will be there. And can you see this defect is going? Since it is a 0 degree, I cannot show. Otherwise, I can turn and then some. Can you see this? No, obturator. Yeah. So obturator, femoral, direct area. This is the indirect area.
So
there is no indirect hernia. This is the direct.
You also explain corona mortis.
Yeah, and 3 triangle. One is the triangle of doom, triangle of pain. Medially, one triangle is there. That is a corona mortis, otherwise called circle of death. So the vessel from the obturator and inferior epigastric and veins will form a circle, circle of anastomosing vein in the Cooper's area. So this is the Cooper's bipolar. Usually in this area it will be there, and it's no need for worry about this, because if you everybody tell if you injury and sort of bleeding will be happen. That's why the name is circle of death. And if you have a bipolar in your hand and you can able to coagulate nicely, so this area is called circle of death or corona mortis. I'll dissect and then I'll sow here. This case, not much vessel is there. And femoral canal is very much clear in this case. Any femoral hernia is there, it will go here. This is the femoral canal, and this is the after this one iliopubic tract, and this is the Cooper's ligament. So we fix the mesh to the Cooper's ligament here. We should not take bone. Periosteum should not be taken. Only this fascia should be taken.
So even the fan shape spreading out of the iliopubic tract is seen here medially.
Yeah, it is seen nicely here. Yeah, triangle shape. Okay. So I'm going for a right side dissection. Right side patient had a little bit bigger defect, direct defect. This is the epigastric vessel. That is the extraperitoneal pad of fat. I'm pushing the pseudo sac. Not much defect seen, must be indirect hernia. So if you are in a right plane, vessels crossing will not be there. So you can do in a bloodless manner. So this is the Cooper's area, Cooper's ligament, and there is not much vessel. So suppose imagine all these vessels are in a very big size. This is called corona mortis. So I preserve all the vessels. Okay, now I'm going laterally, and you can see how to enter the space of Bowgrass, and you can see this epigastric vessel. So up to what level lower limit, origin will be different. Up to what level lower limit of epigastric you are seeing, keep this your instrument and then push the tissue like this. One hand go up, one hand down. One is going up, one is coming down, pushing down. So it's a basically indirect hernia. Such a old age patient has having indirect hernia. So can you see this? I'm not applying any cautery. I'm not dividing any structure. Can you see this space of Bowgrass entered?
Yes, sir.
This is the space of Ritzius. Space of Ritzius. And if you see this, if we fill the fluid and then under CT, if you see, it is like a molar teeth appearance. You can see one space. Now, suppose a drawing a line here, this space coming down, again going up, again coming up, and then going down. So it is like a molar teeth appearance, space of Ritzius, and then this is the space of Bowgrass. So I just create the space.
So on the right side, is there an indirect component or?
Yeah, indirect component. Left side a small direct component. So now you can see this is the post layer of transversalis fascia. This is the post layer of transversalis fascia. I'm going to divide this fascia. Then only I can see the lateral area. So for that, I'm going to use one hook. External view. Can you see this hook? It is like a regular pencil. Regular pencil. I'm taking a regular pencil, and this is the hook by Covidian, Medtronics. They introduced this hook, and you can see it from inside. So need not to have any special adapter or anything. No, this one foot pedal. You can use your hand, stand in a comfortable two leg. You can use this hook. So you can see this is from Medtronics Covidian. Advantage is lateral thermal spread is less compared to the regular hook.
So because you're entered through the right side, are you going to have a difficult vision on the right side, little bit?
No.
Nothing.
Not like that.
And do you always dissect the left side first?
Yeah, because no, I stand on the right shoulder level for initial dissection. That's why I finish the left side first, and then I'm coming to the right side. All my cases, if it is a right hand hernia, then I start only with the right side.
Sir, the place where you are dividing, this is the most common area where your peritoneum can get injured.
Yes, that's why you can appreciate my left hand is pushing down the peritoneum, each and every small cut. Then I'm cutting. That also I pull this transversalis fascia, and then I'm cutting it now.
You are using monopolar or this?
This is a monopolar hook.
Cutting or coagulation?
Coagulation. I don't use cutting. Konja tokka sister. I don't use cutting current in laparoscopically. You can achieve the cutting current even by pressing coagulation. How to achieve the cutting effect in a coagulation current is traction. If you give a good amount of traction, you can see traction is not adequate. That's why you can see this black color. If you see this good amount of traction, then it is act like a cutting current.
So will a 30-degree scope be more helpful to see laterally?
Yeah, initially we use 30-degree scope during our learning time, and then after that we feel that is no need. Nowadays we don't recommend. So even all my PGs, junior colleague, they learn with the 0-degree only, because the vision is adequate, because we are seeing from adequate distance. If it is a E-tap means 30 is required, because you are seeing from above and then seeing down. Here at the same level, no umbilicus just below the umbilicus level, arcuate level, we are seeing it.
So how much head low is the patient?
Can you see it is very less than 20-degree. Inga kami, inga vandu full ida kami, table kami. Wide panni table head low evalan kami. I don't keep much head low in any of the surgery. Here I'll see very less head down. It's 20 or maximum 25.
Okay, so we are having an external view. We've seen.
Yeah, okay. So now laterally dissected, lap you kuduthiru. So from here, from this you can see the attachment I divided. Can you see, no? Yeah, after this I divided. I have to divide some more after paratalization. So this is the hook from Covidian. So it is very comfortable. You can stand in two hand, two leg, and then you can operate. You can see my external view also PIP. I'm using like a pencil, no open surgery. How I'm using the same way. It is a very comfortable one. And compare with laparoscopic hook, the advantage is lateral thermal spread is less compared with this regular hook.
So that hook is reusable?
Reusable hook. They recently launched it, and I'm using for almost 2 weeks, 2 to 3 weeks only. I'm using it now. Very comfortable. Particularly E-tap. When you are doing E-tap for ventral hernia, this is I feel this hook is good and a little bit broader than the regular hook, so the coagulation effect also better.
So, and it works with any cautery?
Work with any cautery. Just pencil is enough. Any cautery it will work. So that is the advantage for a mobile surgeon. So some adapter problem might be there. So this pencil everywhere is there. They can connect with the regular pencil. They can do.
Sir, regarding just we are seeing your external view. So you have both the hands are beside the, you have tucked in the hands.
Yeah. Can you show this? Inge kami, rendu hand kami.
And is this a head low position?
Yeah, it is head low is only 20-degree. And another important thing I want to show you. Can you see my right hand? How I am holding the instrument?
Yes.
Focus, zoom. The down light. See, I introduce only my ring finger into the ring. All other finger is no. I keep it like this. I'm not introducing hand. Suppose if I introduce hand, no, you can see my arm is supinated. Forearm is supinated. Very difficult to work. So if you hold like this, you can see my movement is so free. The same way, left hand you can see I'm holding like this. Can you see this?
Yes.
I'm not introducing hand. If hand means it is rotated. So rotation, forward, backward movement, anything can be done. So like this, if you hold the instrument, even a scissor or anything, I hold like this only. So my movement will be so easier. And we used to call for any surgery, left hand movement is the key for a success of the surgery. Not a success, you can do very better way. So left hand movement should be very much easier way. If you introduce the hand into the finger into the ring, so left hand movement will be restricted.
And what the anesthesia is always general anesthesia, or you do in a regional?
General, sir, always general. I prefer all laparoscopic surgery under general only. Patient is fit for general anesthesia, general. More high risk than I do, but I don't prefer do it in a regional or epidural. Can you see this is the sac? This is the sac.
Yes.
So I dissected initially. You have to dissect the lateral part of the sac. So lateral part of the sac to be dissected initially. So lateral dissected. Now the posterior entered. So now I'm coming on the anterior side, and you can see this some fascia is holding the sac. It is coming and then going around. It is like a holding. like a sling, puborectal sling in a rectum. It is holding. So I'm just dividing the sling. So that is a transverse facial sling fiber, and that is the one is holding the sac. No, we cannot. If you pull the sac, it is not coming out.
The sac looks long, so do you give a push from the scrotum?
Yes. If I feel it is not coming up, any content is there, then I started pushing it. Otherwise, as much as possible, I just pull only. I don't ask the sister to push. So once you divide the fascia, that is a transversalis fascia, then external push will be helpful.
Sir, are you planning to go up to the fundus of the sac?
Yeah. Can you see this sling fiber with my left hand?
Yeah.
This
Yes,
is a
sir.
sac. Yeah. Usually it will be 2 to 3 centimeter thick, broad, and then thick fiber. And you have to be very careful when you are dividing it. Epigastric vessel is very close by. Can you see once I divide the sling fiber, if I pull the sac, can you see how much it is coming?
Yes, sir. We appreciate.
See? So much, no? So that's why your aim is to initially to divide the sling fiber, not dissect the sac. Dissect the sac laterally, then anteriorly go and then divide the sling fiber, because everybody feel that dissection of sac, complete sac excision will produce a lot of damage to the cord structure. But if you follow this technique, your cord structure's damage will not be there. Without any bleed, you can appreciate the white color sac.
Okay, sir.
And so far there is no external compression is being made.
So if that sling is released, the sac starts coming down.
Yes, and that is the initial part of the sling. And then if it is a complete scrotal hernia, then after that it will come cremastic fascia. So initially the sac is held with the transversalis facial sling, then the distal part of the sac is held by the cremastic fascia. That both can be divided without any difficulties. Now you can see, I'm just seeing this. I couldn't reach the fundus of the sac, so now I'm going here, and
So
now
the
this is the posterior.
So the more the distal sac you left in situ, you keep in situ, then there is a high chance of seroma formation.
Seroma, yes. Seroma formation is high. You have to keep a drain, or you have to tell the patient it is a bulge is post-operatively. Everybody have a fear of hernia recurrence. Patient feel that it is recurred hernia, but you have to assure the patient. But if we divide the sac completely, the chance of seroma is very, very less. And some cases, very large complete scrotal cases, then I keep a little small drain for 2 days. Otherwise, I don't keep drain. Can you see these posterior structures, vessels?
Yep.
Yeah. So on and off, I used to stretch the sac like this. I'm seeing same way, stretch is on this side. So all the side just stretch and then see, because can you see, no, when I stretch it, automatically tissue is going up.
It's going back.
That is the advantage of without push from outside. Counter traction, no, by the this one CO2. If you have some hand, the sister is keeping the hand, then this will not go out. So plane will not be developed. So that will create a plane. So I'm not much dissectant. Can you see this sac edge? And then this is just the fascia or a cremastic fascia. Just I'm pushing down. Again, I'm holding it here. Just I'm trying to push the small vessels. It is not a big main vessel, but even though I want to preserve that vessel.
Sir, if you are able to release the fundus, there's no need to
No, it is a fundus.
tie the sac.
It is a fundus. You can see.
Yes, there's no need to tie the sac. You can just
no need to divide the sac, tie and divide. And only thing, if you injure the sac, any hole in the sac, then you have to apply loop or some suture. Usually I apply loop. If a sac is not open, and you can leave it, it will go inside. It will invaginate, and then it will go inside. So the distal part of the sac is held by the cremastic and the vessel, posterior vessel. Now slowly I am pushing the vessel down.
So the fundus
stretch like this, each and every time. See where it is, which structure is holding the sac, and then separate the structure from the sac.
Sir,
can you see one thin layer is going?
Any tips to avoid injuries to the vas?
Yeah, that is very much posterior. And when you are doing a medial side, then I have to stretch like this, see, and then I will cut. Can you see this vase here? Here, if I stretch, it will appear here. Can you see this?
Yeah.
So when I dividing this, always I stretch like this and then see what structures to be divided, and then I'll divide it. Without stretching, just divide means if you go close to the sac, usually when you are doing a sac dissection, everybody's advice is go close to the sac. Some surgeon used to tell hug the sac and then dissect, but it is not possible. Always, if you do like this, when you go posteriorly, you will injure the vessel. So my advice is each and every time just stretch the sac, stretch the sac like this, and then see which structures to be separated. So all the structures close to the sac. In open surgery, with the pad, mop, they used to push. I think or scissor you can cut and then separate. The same way under vision with the magnified view, and you can see here I'm operating with the 55-inch monitor. Is the monitor external view coming? So nowadays 4K system with a very big screen, your view is so good. Each and every small vessel you can able to identify. So your injury to the vas gonadal vessel is very much unlikely when you are dissecting the indirect sac.
So we will just shift the audio to the other theater.
Yeah, okay.
Dr. Patsade, we'll come back to you, sir.
Yes, yes. Okay.
Right. Dr. Prashant?
Prashant sir, we are live with you. So can you explain what you are doing? We can see the beautiful ICG picture inside.
See, I have inserted the fifth port also.
I guess indirect.
And you can see from outside how the fourth port
ஒரு 88 இயர்ஸ்னா நம்ம டைரக்டாக திங்க் பண்ணுவோம். அதனால தான் நான் போட்டேன். நல்ல வேலை அந்த முருகேசன் இன்டைரக்ட்னு சொல்லி தான் வேண்டாங்க. சம்டைம்ஸ் டிஃபிகல்ட் ஆகிருங்க. பட் எனிவே சாக் டிசெக்ஷன் கான்செப்ட். இல்லை அது போடக்கூடாது. எப்போவுமே வந்து ஹர்னியான்னு தான் போடணும். நீ இந்த இன்வேஜினேஷன் டெஸ்ட் அந்த டெஸ்ட் இந்த டெஸ்ட்லாம் நான் பண்ணுறது இல்லையே. See, very thick spermatic face. Nothing is there here. There is no sweetless structure.
Back here was very high, and the duodenum and the colon was so coming very close.
சரி, சூடோசோக் பிளேக்கேட் பண்ற வேலை இல்லை. டக்குன்னு மெஷ் ரெடி பண்ணு. இப்போ காமிச்சலாம். 17-12 கொடுக்குறியா? லெஃப்ட் சைடு ஃபர்ஸ்ட் கொடு. பார்த்துட்டு இதுக்கும் 7.
One of the assistant is holding it down like this, so that I will be able to see the common bile duct. Just catch it like this, and you are seeing that I am with the gauze piece inside. Always the gauze piece should be with radiological marker. Here it is not available, but now I can see the complete gallbladder, which is small, shrunken, liver is cirrhotic, and the cannot strangle is not at all seen. So it is grade 4 difficult gallbladder, and even the ICG is not helping because of the fat available and fibrotic tissue available here. So you can see little bit of common bile duct here down. You change it to the contrast.
Yes, we can appreciate the little bit of CBDs in there.
In contrast view, it is better appreciated. So I will have to trace the change.
Yes.
Okay. So this is only mode where the tissues are seen in normal color and the bile ducts, they are seen in green color. So this is overlay.
So you must be feeling the stent also, no?
No.
Difficult at present, but I will have to dissect all these tissues so that I will be reaching the exact cannot there.
What energy source you are comfortable with?
I am using this Herbe Trisec Rapid. It is adding monopolar, bipolar. So I will dissect down bit by bit, very slowly. I don't want any catastrophe here, no vascular or biliary catastrophe. And we try to remove, skeletonize it,
Can you explain why you chose to dissect at that level specifically? Why not below or why not above? So you have started the dissection.
I can see only the fundus of the gallbladder.
Yes.
Yeah. And that is dissected. So my next job is to create a posterior window. But where exactly the posterior window is to be created? I will have to shut off this fat at this particular level. That I will be guided by the ICG imaging bit by bit. And we have given the ICG at 4 a.m. in the morning. Then we have that's very well in the normal anatomical colors. Otherwise, everything will be.
இங்க மேல
Timing of the ICG depends on the system we are using. If we are using or the primitive one system, then we have to give it at least 10 hours before.
இது கொடு சிஸ்டர் அந்த இதை காற்று கால் கிட்ட கொண்டு
We are using good system, just like 1788, you have to give lesser diet.
வெளிவா கூப்பு போடணுமா
Expecting some collateral here
ஆ
because the patient is having total hypertension.
ஆர்குவேட் லைன் வரைக்கும் வந்துருச்சு
Therefore, I have inserted one gauze piece which is to be kept handy. And we try to do hemostasis then and there only.
நிற்கவே முடியல
Don't want any change.
ரொம்ப திக்கா இருக்குது வேணா
For our vision also.
So do you any time try the fundus first technique? Dissect the fundus first.
When you are not able to see the callots and doing fundus first, definitely the chances of biliovascular catastrophe are high. Therefore, the second alternative is to transact the gallbladder here and then go down. You know exactly where the gallbladder is. Learners, they can do this also. If you want me to demonstrate that, I can do that. I will transact here, give traction, and then go down here from inside.
There is a vessel.
That is also one of the options here.
Intact fundus, because the intact gallbladder will give you help you in giving a good traction. Once you transact, it will be little difficult.
Yeah, we will see how difficulty we find during our dissection. Otherwise, we will do that transaction and then do that.
எங்க என்ன ப்ளீட் ஆயிருக்கு கூட சக்சன் கொடு
So, anybody is having any idea how
ரைட் ஹேண்ட் பக்கத்துல போட்டாலும் நல்ல டிசைன்
very simpler way? I think this is very thick tissue here. So it will be better if I can go.
இங்க இருந்தா போயிருக்கு இந்த இடத்துக்கு தான் ப்ளீட் ஆச்சு அப்ப நான் படுத்தா பைபோலார் போட்டுருக்கேன் சிஸ்டர்
Removal of this fat. I might take some time while doing this surgery.
ப்ளீட் ஆகுது கூட பைபோலார்
I will be slow.
சக் கூட பைபோலார் டொக்கர் பிடிச்சுக்கோ பைபோலார் கால் கிட்ட வை
I made coagulation first. So this is coagulation. Releasing it and then.
Sir, we'll come back to you. We'll go to the GEM hospital.
Yeah. Also,
Hello.
The team
Go back
from
to Dr. Pathsarthi.
Also,
Yeah.
the team from Kerala Hospital is ready with the case. So the second screen will be shifted to Kerala for a mini gastric bypass.
Yeah.
And GEM Hospital will continue with the PTEP.
Yeah. Hello.
Okay, sir. Right, sir.
Yeah, I dissected the sac completely.
Okay, go back.
Are you with me?
Are we with the GEM Hospital?
Hello.
Dr. Partha,
Hello.
sir?
Yeah. Hello. Am I audible there? Hello.
Dr. Pathsarthi?
Dr.
Yes.
Partha, sir?
Hello. Yeah.
1 minute.
Hello.
Are we shifting screen 2 to Kerala?
Hello.
NGP?
Yes, sir.
Yeah.
So-
So that's Dr. Muhammad Ismail from
Hello.
Kerala. He's going to demonstrate mini gastric bypass for obesity.
Bipolar கொடுத்துரு. Hello. பிடிச்சுக்க.
Ismail sir, we are live with you.
பிடிச்சுக்க.
Are you able to hear us?
Yeah, 1 minute. They have not unmuted. Can Perindalmanna team unmute, please? And Cheese, keep yourself muted. Perindalmanna, could you unmute, please? Ashik,
கொடு மெஸ் கொடுத்துரு.
unmute.
இன்னும் கொஞ்சம் எடுக்கணுமா இங்க? சக்ஷன் கொடு. ஏன் அங்க பில்லிட் ஆயிட்டே இருக்குது.
Ashik,
டொக்கார் மட்டும் வெளியே வந்துரும்.
Perindalmanna.
சக். 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 கொடு கொடு.
We will go to the GEM hospital.
பைப்போலார் கேட்டா தான் வைக்குது. ஹலோ.
Partha sir.
Hello.
Yes,
Am I audible? Okay.
Yeah. Please.
Yeah, I just completed the left side dissection. Can you see here, left side, it is complete
Yes,
sac I exercised without any injury.
Yeah.
And I'm taking my camera. Since it is a 0 degree, I cannot bend. You can see entire sac, no bleeding inside. And this is the vast different gonadal vessel. Laterally, how much you can see from the internal ring. It is more than 10 centimeter dissected. And if you want, you can dissect further also. After keeping the mesh, I will decide whether it is dissected or not, required or not. And this is the triangle of doom, vas medial border, gonadal vessel lateral border, triangle of doom. This is the triangle of pain. Here also I preserve this fat.
So what
And this is the Cooper's ligament, and this is a small obturator hernia is there. I exercise, and this is the external iliac artery, external iliac vein. Yes.
So what is the lateral limit of your peritoneal dissection? Lateral
Yeah, I want to two things. One thing is above the level of antesuppiliac spine. This is antesuppiliac spine. You can see my dissection is went above the level of antesuppiliac spine. Basically, from the internal ring, we want around 7-8 centimeter. 8 centimeter. So I have to dissect this peritoneum little bit curved. And after keeping mesh, I will do that. Just I want to show you. So this peritoneum, if you want to divide, separate, I will separate. This is the dulux fascia. I will divide the dulux fascia. Peritoneum, if you go laterally, don't try to push it. Sometimes it will injure. So what you do, you can hold this fascia and then just touch the fascia like this, then it will go. Guess close.
So
and another thing I want to tell you, two things. One thing is you can see all the fat is covering the triangle of pain, and here also vast difference you can see one layer is covering. It is not a very bad vessel or vas, and you cannot see any dark area. If you see this much dark area, that means I will give more current. So this area there should not be any dark points. Dark points. That means cautery is no traction is good. Cautery is very judiciously used. I'm going to take a mesh. Already I showed external view, and this is 18 into 13 centimeter mesh I take, and then trimmed into 18 into 12, 18 12 17 12, 18 into 12 centimeter I will take it. Usually I keep it 17 12 is my routine this thing, because usually I dissect laterally well. This case sister gave 18 12. We'll see how much left side mesh this one, and only laterally it was got trimmed, and you can see one uncut end, it will go superiorly. Yes.
yeah, sometimes superiorly the peritoneum is very adherent lateral to the linea semillunaris.
Yeah.
Any tricks to?
No, we are going a little bit on the transversalis facial side. Patient light injection put.
Partharthi sir will continue watching you. By
Okay.
the time, Dr. Ismail sir has joined in from Kerala.
Yeah. You can.
Have a case capsule from him.
Thank you,
Okay.
sir.
Ismail
Thank
sir.
you, Dr. Patsadi. Right. Over to Dr. Ismail.
Yeah.
Yes, Dr. Ismail, welcome.
Dr. Ravindra Bhate, Dr. M.M. Sarnaik is the moderator.
So what port position, please? Yeah.
As you know, the patient is in a supine position with the legs apart, and I'm standing in
Good. Bipolar.
holding Dr. Matesh, holding the camera, and my sister Sindhu Rahman resistingly. And there are 5 ports we are using. Can you just show can you see the abdomen?
Yes, sir.
So a better view, please. We are not able to make out the ports properly. External view.
நல்லா பிடிட்டு உட்காரு.
Yeah, it's better now.
അല്ല അശിക് കുറച്ച് വൈഡ് ചെയ്യണം. Can you widen out please? Thank you.
Is it alright?
Yes, sir.
Yes, sir. We can appreciate.
So the supraumbilical tendon port I put for the camera, and the laterally this port is for the liver retraction, and later I am going to use for the suturing also the same port. And there is an epigastric port for the first and second staplers, and the lateral port for the retraction here. And this is 5 mm and 2 basics I am using, and this is for the other staplers, thicker staplers I am going to use. So there are 5 ports, and I believe the first the stapler has to come from the epigastrium, because you can put the first stapler has to go distal to the
Yeah, can we go to the laparoscopy view
Yeah,
now?
we need a laparoscopy view now.
Internal view. Yeah, Ashik, Ulil.
Yes.
Right.
Can we have a case capsule in short? What the case is?
case capsule is already shown.
No, sir, nobody showed us, sir.
கொடு இந்த பக்கம் எடுத்து
Case capsule. Can you see
கொஞ்சம் லேட்டரலா.
Yes, sir.
கேஸ் போயிடுச்சு.
Can I go slide show, please?
slideshow? Next
The
slide.
next slide.
Allah, full screen.
சூச்சர் எடுத்துக்க டக்குன்னு எடு, முடிச்சிடலாம். 10 மணிக்குள்ள முடிக்கணும். 10.
Yes.
உட்கார், இழுத்துக்க கொஞ்சம் காமி. ரைட் ஹேண்ட் உட்கார் காமி. போதும்.
The box balance. No, I think they're not. It's just rolling PowerPoint. Oh, it's saving. Just a minute, sir. Perfect.
Next slide.
So patient has a hiatus hernia also,
Yeah.
and Hill's grade 3 esophagitis. Yeah.
Right.
So that's why we changed the plan from this to MGP.
MGB,
Right.
yes. Because of risk of reflux. Yeah.
Position is all right. Shall I proceed with the
Yes, sir.
Yes, sir.
Yeah.
We are waiting for you to start. So what is your first landmark? Yeah.
So this is the crow's foot, and we have to enter into the curvature beyond the crow's foot. So you can see that here there are some vessels. I am taking it with the harmonic.
ஓகே, go.
So the first port, I would like to put it from the epigastric port, so that the success of the FTP, I would say, it should be allowed to
வெளியே எடுத்துரு.
at the base of the tube. The tip of the tube should be wide. So to get a wide the tip of the tube, you should have a cobra slit. It is called, or it's a triangular shape. You can see the pancreas.
Yes, sir.
Sometimes you use the additions, and in that case you may have to do some dissection. But in this case, luckily, I am having a low BMI patient, so I am going to put the first stapler. The first stapler is 45, a blue 45 I am putting.
ஆப்டேட்டர் ஹர்னியா இருந்துச்சு.
And power. And this should be perpendicular. Actually, the actual position is the junction between
சரி, ஓகே.
the body and the
ரெடியா இருக்கு சொல்லு. 5 மினிட்ஸ் தான் முடிச்சிடலாம்.
the action. You can see the blood vessels coming here, blood vessels going here. So this is the ideal position, so that we will get. And the next stapler I am going to put parallel to the breaker curvature and then up, so that you will get a triangular shaped tip of the pouch, so that we can do the anastomosis without making any ischemic part of your stomach.
So do you use blue stapler in every case, or do you change it in
Yeah,
some?
if the antrum is too thick and then I may use a gold or a green. But most of these cases, I believe blue will work well.
When will you place the bougie?
Mr. Kamchari.
That is after the fourth stapler.
Down.
So the next,
Suction.
because I'm going to.
So this stapler is also coming from the epigastric port.
Epigastric port.
Can we have PIP for the Kerala hospital outside view?
PIP, please.
PIP for the there.
Make sure that you are not closing the greater curvature.
பசுபதி ஆனதுக்கு ஃபோன் பண்ணி சொல்லு முடிக்க போறாரு ஆடியோ கொடுக்க சொல்லு.
I'm going to put from the left mid right port, lower port.
So how will you know that you have reached the
Suction கொடு.
lateral end? Is there any particular technique you use to the greater curvature? Greater curvature?
Yeah, you can see that. Show me the greater curvature. See that? This my second port is second stapler is almost parallel to the greater curvature. You can see the space there.
So is there any particular distance you are looking at?
You are looking at the marking in the stapler. You can physically see it.
Okay.
Ready? இங்க வா இந்த
How
sack
to
எடுத்து.
prevent the coiling or the spiraling of the sleeve? Sometimes
Yeah, that's what. And the vertical
Invasion height.
that is, you can see that
இங்க
there
தான்.
is towards the
Surrounded.
curvature.
Yes.
I usually don't disturb that because that will keep the tube straight. And if you use a wide, you can see that a wide tip of that tube, and vertically this staplers should be in a vertical.
ஏய் ரெடிடா சீக்கிரம்.
Usually there won't be any spiral.
எக்ஸ்டர்னல் காமி சும்மா நின்று
The
இருக்காங்க.
sleeve you want it to be.
எக்ஸ்டர்னல் இருக்கா
You
ஃபுல்லா.
are comfortable with the loose.
சும்மா தான் நின்று இருக்காரு.
It should be always a loose sleeve because we are not keeping that tube as we are doing it in a sleeve. Now, the next
ஸ்க்ரோட்டல் லைட் அமுக்குது. எடுக்கிறப்ப ஸ்க்ரோட்டல் கேஸ் எடுத்துறணும் லைட் அமுக்கு.
is to, you can see that there is some
இல்லைன்னா நீடில் போட்டு எடுத்து. அமுக்கு வேண்டாம் விட நீடில் போட்டு.
towards the greater lesser curvature. So, I am not going to disturb it.
So excuse us, we are going to shift to Dr. Parathasarthi.
Yes,
He's nearly
finished the case. So Dr. Ismail, we'll
Hello?
keep watching you, sir. We'll get back to you on the audio. Over to Dr. Parthasarthi again.
Hello. Am I audible?
We can hear you.
Hello.
Yeah, we can hear you.
Yeah. You can see this mace I fixed to the left cooper, and then right mace I fixed to the right cooper. So this entire mace 18 by 12. You can see how much it is down, and here is little down to cover the operator area. Again, the right side from the internal ring, you can see the mace is up to this level. So it is almost around 8-9 centimeter, and there is no folding of the mace. And this is the sack which I mobilized without any defect. So I just keep it there, and I'm going to suction. I'm going to take out the gas now. And when you're taking out the gas, you have to take care of the mace lower border. A small vessel that will be.
Sir,
Yes.
with such good dissection, with good space and large mesh, is it really necessary to fix the mesh?
Yeah, it's no need. Actually, it's no need. But our practice in GEM is to fix the mesh all the time to the cooper. That's why I expose the cooper nicely. You can see even over the mesh, it is like a light house like. So I'm desufflating very slowly. I don't desufflate very fast. And so you can see both the side, it is coming out. It's a bubble is coming out here.
So do you use a non-absorbable suture or?
Non-absorbable, Prolene suture. So always desufflation to be done very slowly, should not be fast. slowly, and you can see it is coming up. Peritoneum is nicely coming out with that over the maze. And here there is no pneumoperitoneum created, so I don't have any trocar inside the abdomen. And if you have any 3 mm or 5 mm, what you do, you can connect the gas through the 5 mm trocar, and then with the 5 mm scope, you can go inside and then you can see. Once again, I'd like to thank the organizing team of Masikan 2025, Dr. Anand Kamath and Dr. Pratap Varute, to giving me this opportunity. Next case is ready. And I'd like to thank
Round of
my
applause,
moderator.
Dr. Bharat.
Yes.
Can you
big
hear the
round of
applause, sir?
applause for you, sir.
Okay, thank you. And I like to thank my team, operative team, and then my AV team, Mr. Pasubudi, Alagar, and Selva Kumar, and my technical guru, Venkat sir, because I can able to transmit the HD quality. I think you will appreciate the HD quality without any delay. I'm not using Zoom; it's a different platform. That's why I'm able to show this, very nicely with a very clear view. With this, I will finish. Thank you so much.
The audience wants to see your monitor.
Monitor.
Your monitor.
1 minute. நல்லா வெளிய இந்த பக்கம் இழுத்துட்டு வாடா. இப்படி வெச்சா எப்பறா தெரியும்?
It's a 55-inch monitor as you had specified.
Yeah, that is a Sony monitor. Wide வெச்சு காமி. Yeah. Are you seeing this?
Yes, sir, we can see.
Yeah. Okay. Thank you.
We'll shift the audio to
Thank you so much. Thank you.
So
Thank you, sir.
we'll now. Sir, where would you like the audio to go to?
Ismail, sir.
With Dr. Ismail. Back to Dr. Ismail, please. Ismail?
Hello.
Yes, sir. We are back with
You
you.
can see that after putting in 2 more codes, I have reached the cardiac junction, and posteriorly I have taken over to short-gastric vessels to enter into the cross. We are going to keep 1 centimeter of the fundus here, not very close to the cardiac junction. 60.
So did you introduce Boji?
Boji is still here.
Still here. Oh.
You can see that the Boji here.
Yeah. Okay. Which French Boji you have used, sir?
So 36.
36.
Dear friends, I thank
So you can see that this maneuver you have to be little careful. Sometimes there will be additions to the spleen. So you are putting the staplers away from the cardiac junction. And I will see whether I have closed the stomach or. You can see that the staplers are gone, and the cut always it happens 2 to 3 millimeters beyond the staplers. Scissors, yeah. So I can safely cut it, but if there is the stapler hasn't gone through, then you may have to use another stapler.
Any particular reason why you leave 1 centimeter of fundus behind?
To prevent injury to the cardiac junction, because always the leak happens usually from the esophagus rather than from the stomach. So you should not injure the esophagus, cardiac. Now what I am going to do, you can see that the stapler, the tube is here, and it is a vertical, and because of the Boji, it is like that. Camera down this.
You are planning to do any crural repair?
This one where we can put the GG. I remove the liver retractor.
Are you planning to do any Ismail sir, are you planning to do any crural repair for this patient since he has a hiatus hernia?
Yeah, I don't think so, because the NGP itself, what happens when we are anastomosing the intestine to the pouch, that itself means a pull this one. And you can see that there is not much show me here. Not much this stomach, you can see the esophagus here.
Yes.
So in the MGP, if you do the MGP, definitely you can, you don't have to repair that because there will be a hold.
Right. Sir, we'll keep watching you, sir. We'll just get back to you. Gem Hospital, can we have?
Dear friends, I thank organizing chairman Deepak Patel, secretary Anand, and Pratap Baruti for making Gem Hospital to be part of MasiCon, a wonderful conference. I truly am missing Kolhapur. Wish you all the best. And today, since I have to travel to Bhopal, Madhya Pradesh SI, and I'm on the way. For that, what I did yesterday, I did a e-tip with the tar, and that video will be played. And on behalf of me, Nalangali Senior Surgeon at Gem Hospital will give me a comment. And you can have any questions during us. He is an expert. He's been regularly doing it, and he's capable of clarifying any doubts of you. And Parsarjo also is available, and I hope his demonstrations went on so well. And I promise I will love to come to next MasiCon and with all of you physically. Wish the conference to be a great success, and thank you very much for this opportunity for us to demonstrate.
Good morning. Good morning, everyone.
Yeah, please go on. Please go on.
Anand sir, can we go to Gallbladder Theatre?
Just 1 second, sir. Gem Hospital, can you start the video, please?
Started. That's virtual live is started now. Is it audible?
Yes, yes. Please start playing.
Can I go forward?
Yeah, please.
Okay. This is that port placement for the E-tape. First, initially, we will place the 12 mm OptiView left subcostal region, just 5 centimeter away from the midline, 2.5 centimeter or 3 centimeter below the left costal margin. That's the initial trocar placement. We'll use the 0-degree telescope while entering into the retrotrocari space. After dissecting adequate space, we'll place the second trocar at the level of the umbilicus or just above the umbilicus, just medial to the linear semilunararis, that is the 10 mm trocar. Then another working port 5 mm trocar just above the arcuate line or below the umbilicus. That's also just medial to the linear semilunararis. One more trocar on that right side subcostal region. This is the trocar placement for that routine E-tip. So for that understanding of this only, I showed first initially the trocar placement. Now going to the virtual live. So with
Hello, what is the case, sir? Can you just give a brief history of the case?
This is the umbilical hernia with the bilateral inguinal hernia. So this is the best ideal case for to do E-tape, because otherwise you have to do tape with IPOM. So in these cases, E-tape is the best choice. So we initially placed OptiView with the 0-degree telescope. So initially we entered into retrotract space, creating adequate space with the help of that new carbon dioxide insufflations. After creating adequate retrotract space, the 10 mm or 5 mm additional first trocar is placed at the level of or just above the level of the umbilicus, just medial to the linear semilunararis. This is the linear semilunararis. So with this first working port, we are developing further adequate retrotractor space. There is small vessels piercing the post-erector sheath. So you should always hug the post-erector sheath where the piercing vessels are very small. So if even if you dissect blend dissections, the bleeding will be very minimal. So we are hugging the post-erector sheath, medial to lateral or lateral to medial. Our aim is to create the retrorector space adequately, more inferiorly, because you have to place the next working port at the level of the arcuate line or the just above the arcuate line. After that only you can operate 2 hands. So this patient is having bilateral inguinal hernia. So we are doing the dissection below the arcuate line. Otherwise, up to arcuate line or just below the arcuate line is dissection is enough. So you have to dissect medially up to the linea alba, or you have to see the medial border of the corresponding rectus muscle. So now we are doing the left side. So this is the left rectus muscle. So you have to see the up to the medial border of the left rectus muscle. So here we are
Dr.
using,
Nagini,
yes,
we'll keep watching you. We just need to shift on audio to another theater and come back.
okay,
We'll keep watching you. We'll come back to you on the audio.
okay.
Right. Can we go back to Dr. Prashant Rayate, please?
Prashant sir, your mic on, sir.
So we were watching you.
Since we have left, I have dissected or transected the gallbladder at this particular level.
Yes.
Where the complete frozen callots was there, removed all stones from there. Now, whatever I am seeing the residual gallbladder here, but I can appreciate little bit of stones there. Therefore, I am dissecting this with again in harmonic standpoint. And if we can see inside, the cystic duct has almost been there. Yeah. Okay, so my plan is to dissect little bit here, remove all the stones, whatever stones are there, and then we will look it there.
Are you planning a subtotal cholecystectomy or you will go for completion?
I think the cystic duct is at this level.
Sir, how will ICG help here then?
ICG, with these particular fibrotic structures, ICG will not help much. Already the ICG board is going on, CSF board is going on. Okay. So this blue structure is the CSF board. Here you can see even the gallbladder is not having much of the bile. Otherwise it could have been red completely. It is seen as liver is seen as blue.
So it will not delineate the cystic duct.
It will not delineate the cystic duct because there is too much fibrotic structures. So in such cases, it is better to do under vision everything. Even the cholangiography, intraoperative cholangiography will also not help much because we have already gone up to the level of the cystic duct section level.
Dr. Prashant, Pramod Shinde here. Yeah, I thought that the ICG was more for identifying the CBD, isn't it? But we can't see even that here. Okay. And
Shortcoming of the ICG.
okay.
That is for you have to skeletonize it. But here doing skeletonization is also
My speed 1.3 then.
applied into some structure which is not seen. So if you can see here, there are few stones here you can appreciate.
Yeah, we were seeing that you removing the stones also. Yeah. My second question is, after if you feel that you've removed all the stones, wouldn't the cholangiography help you at least say that there are no residual stones in the cystic duct? Because sometimes we can miss a cystic duct stone which is stuck deep, and then that will not be accessible through the CBD ERCP route also. So wouldn't the cholangiogram help you in two ways? One is to delineate the anatomy better, since ICG is not helping. And secondly, to confirm that there is no residual stone stuck beyond what you can see in the cystic duct.
Definitely it will help.
But how would you do a cholangiogram with the cystic duct not seen?
From here and flush it. If the feeding tube can go inside, then the path is okay. If feeding tube is not going inside, then I will have to dissect it down more.
Yeah.
I will be taking some time. Very slowly I will be.
Right. Dr. Rayate, we'll keep watching you.
Prashant sir,
sorry.
Prashant sir, hello. Prashant sir, Sanjay Ghate here. Sir, will you prefer the colodoscope or the cholangiography? Colodoscope.
Colodoscopy.
I think, see, this is the 5mm instrument which is not going in. That means the lumen might be less than around 3 millimeters. So 3 millimeter scope, they are not available at present in India. 3 millimeter scopes passing through the cystic duct into the CVD. They are called as the cystoscopes. And these scopes instead of doing ERCP, they do small opening in the cystic duct and insert that
take a question in the
the
system.
flexible scope inside, but they are not doing
There are
it.
stones
They are
will
made by
not go down and will not be able to.
Ideally will be a intra-op ultrasound.
If the dye goes down, we'll be able to see the dye
laparoscopic.
there is some anatomy. And that
Right. We'll keep watching you, sir. We'll get back to you on the audio. இவங்களை mute பண்ணிட்டு the Achi is mute. Dr. Ismail, we are coming back on audio to you, sir. Can you unmute, please?
Ismail sir, we are live with you. Ismail sir?
No, they have not unmuted. Ashik, unmute. Ashik, audio technician there in Perindalmanna. Unmute Chay. Yeah, we
Ismail
can.
sir, we can hear you. So at what distance you have selected the jejunal loop?
So we have taken 180 centimeters. Usually we are only if the BMA is more than 40, we usually take 200 centimeters. And as the patient's BMA is less than 40, I usually take 20 centimeters less, 180 centimeters. And we are going to put a posterior. We can see that from this side, and you can see that there are two staplers coming adjacent.
Yes.
This is the thing you have to take care. It should not be very close, because in between this tissue should not get STD. That is the one of the reason why these patients are getting the marginal. So if you have the anastomosis should be towards the lesser coverage. Towards the lesser coverage.
Yeah, appreciated that.
So I am going, this is a 45
महेश
amount
लक्षात
low
ठेवायला
stage.
4 दिवस ठेवायचा आहे का महेशला फक्त फोन करून चालू करायला सांगितलं.
And you have to see the stable line inside because there should not be any bleed here. Otherwise,
That's the only problem.
most of it will have bleeding.
Do you oversee your staple lines?
Not all. This stable line I will suture when I am suturing the closing the endotomy. But not generally now. I mean, even this sleeve and this one, I don't usually oversee. Stitch this. I am using a PDS, 20 PDS for the suture, and typically I am taking on the in 2 layers I suture. Put a knot, and this is a 25 centimeters suture.
So can we shift to screen 2? Gallbladder. Can we shift to gallbladder case, please? Audio.
Sure. Ada mute பண்ணிரு. Prashant. Cheese, can you unmute, please? Dr. Prashant.
Rahate, sir.
Prashant. Hello, Dr. Prashant.
Yes, sir.
So,
As I have already told you, that cystic duct was dilated here in this case, and skeletalizing the tissues in the cannons. I will be very careful.
so Prashant, sometimes we use the CM to see where the stent is and get a judgment of how far we are from the CBD. So would that help?
We have worked from the
use of ureteroscope in this and what energy source is required.
So can you show us that infrared imaging ICG? Yeah.
So there's a question from audience. Which energy source you are usually comfortable in such difficult cases? And
combination of harmonic, bipolar,
and whether you would use a cystoscope or something to introduce into the remnant gallbladder to evaluate that cystic duct and the remnant stones.
See, I have pulled down with the help of the fifth port, the duodenum and everything. Now I am converting the image to the contrast see that CBD line is here. So CBD will be up to here. Now change to the normal view. Normal view. So, and I am dissecting at this level. So I still have at least 5 millimeter. So I will be dissecting down here. My complete target will be to see cystic duct. Already I have gone almost 1 centimeter down, pushing all this fibrotic structure and the canals. If 5 millimeter I go more, then I will be happy and I will not be taking any residual gallbladder.
Sir, are you able to feel the stent?
No. Can't able to see palpate this state. It is too much fibrotic here. Fibrotic and fibrotic.
Ratesh sir, this is Dr. Vaibhav Mudare, surgeon from Kolhapur. Yeah, any guidelines for such very bad gallbladder and frozen callots for especially newcomers? Any guidelines? How far we should go dissecting that area? How far it is safe? Or are there any guidelines?
Do up to this come out, put a filling tube, flush, the residual stone should come out and
Yeah, maybe experienced surgeon like you can go till you find probably the.
it is still risky for the experienced surgeon.
Yeah, of course, I agree.
So if we are going to leave this stump of gallbladder behind, would you close the cautery, the mucosa and close it, or would you decide on a fenestrating suture?
I will cauterize it, already stent is there, so I don't think that leak will be a problem. Don't close it, come out. If you reconstitute the gallbladder, the chances of reformation of the stones.
Okay.
Yeah, stone burden has to be cleared from that area. Maybe the ureteroscope sometimes helping to see any stones are there inside. And
Ureteroscope will help.
Yeah.
So you would not actually close this stump? What if there is a wide cystic duct and it's patent?
Sir, what if the stent was not there?
Question, if there is a leak, post-operative leak, then the patient will need a ERCP.
No. If there was no pre-op stent, then would you close or just leave it open?
No, I am not understanding.
If pre-op a stent was not put in the CBD, there were no CBD stones.
Exactly. If there is no stent at present and if the post-operative leak persists, white leak is there, then you do ERCP.
No, you will still not intraoperatively. You will not close the gallbladder.
Because there will be a little bit of fibrosis and there will be some sustaining of the mucosa which will keep on the disease line. So if you don't close it, that will help by fibrosing the mucosa. You are already updating the mucosa. See, there is a stone there.
We got Dr. Jignesh here from the OT and I am with Rakesh sir. So we have, I think Pramod sir asked a question. So we have published this series where we used intraoperative CR because then what happens is that you have a margin to know that how far you want to keep dissecting downwards. And as you can see, sir is trying to look out for that stone also there. So in such scenarios, Dr. Rathi, would you also put in a 5mm scope and try to see because that stone is still sitting there at the high level, isn't it?
Yes.
Yeah.
I am planning for that.
Definitely. Okay. So, Vaibhav, answering to your question, in the people who are new, if it's a stented gallbladder, then use CR, which I say it's the poor man's ICG, where it makes life very, very comfortable, and then you can keep going down very comfortably. The only thing is that at 12 o'clock position, when you're very close to the right hepatic duct, one needs to be a little bit careful because it comes in very close to the gallbladder in the cases like this, where it's stuck.
And Prashant, sometimes, and Jignesh, sometimes infant feeding tube is a little floppy. We sometimes use the ureteric catheter, to help us do a cholangiogram, because of course cholangiogram is not very easy in these situations, but it's worth a try many times because the dye passes through, although the duct or guide wire may not pass through.
I agree. But with the stone scenario, sometimes, sir, even that will be much thinking back. But
இங்கே மூவ் பண்ணி விட்ருங்க. இங்கே நல்ல டிசெக்ஷன் உங்களுக்கு பெருசாக தேவையில்லை.
Yeah, absolutely agreed. I use the CM quite often there. Yeah.
ஓகே, எப்படியும் ½ hour தான் இருக்குது நம்மளுக்கு, சரியா இருக்கும்.
Hello. Hello, I'm Dr. Vinay Mehendale. In case of bad gallbladders like this, and when you're not sure that the stone is left behind, you don't have C-arm, you don't have ICG, it is better to do subtotal cholecystectomy and leave the stump open. That is safer than trying to close it. No, you can do laparoscopic subtotal cholecystectomy.
sir, when you say keep it open, that means you will obviously have a leak, isn't it? Or no?
That leak is better than leaving a. See, the leak will stop if the distal tract is patent. For which, if the leak persists, you can always do ERCP and put a stent. Because even like they say that what they called it as fenestrated subtotal cholecystectomy, but if you close it, even if you suture it, it is never waterproof. It is never water, and it is trying to close it, and if you are occlude the stump with the stone left behind, it is much worse than leaving it open. Don't be worried about the leak. Worry about the safety of the whole procedure.
That's important. I have removed the second stone also, and you can see now this is the opening here. I will flush it and see it properly. Irrigation there.
Sir, in this present case, in case you are not going to do operative cholangiogram, I would still leave this open because I don't know if there is any more stones left behind or not.
But in this particular scenario, we could see the stones inside.
Sir, can you put on the ICG mode? We can see if we can. Is it off helpful?
So take time, be patient, let the bile come out of that, then only you are sure that you have completed the procedure. I think now everything is supple here. No stone will go down inside. I will put a 5 mm board from the epigastrium and we see whether any stone will be there. I can see even the part of the CVD which is there. 5 mm board. I
think this is the ideal case for doing the
So that one a big stone
because there is going to be a
Hello, Prashant sir. Prashant sir. Hello, Prashant sir. Through this epigastric port, instead of 5 mm scope, ureteroscope, 6 French ureteroscope will be helpful. And have you any experience? If anybody?
We are regularly using in my system. I am having the eximal endoscope, the eximal ureteroscope.
Yes.
Which is 3.3 mm only.
Okay.
And it can go inside the.
Which will you prepare? Which will you prepare?
See, the rigid scope can clear the CVD because of the movement. flexible will be better.
Telescope, ureteroscope, flexible ureteroscope. Which will you prefer?
Flexible will be better.
Okay. Yes, sir. Thank you.
Because the rigid telescope we have seen even in some conferences that it can tear the CBD.
Hello, Dr. Prashant. Yeah, this is Dr. Prabhu, GI Surgery KEM. This is an ideal case for getting an intraopcolangiogram. I don't think you should do anything less than an intraopcolangiogram because that stone seems to have coming. Yeah, it seems to have been coming from the CBD. Because you can see a lumen above and from which there is a good amount of bile which is coming out. It is probably the right hepatic duct which you are seeing right up there.
Yes, it's good. 100% right. And we are planning for the same.
Right. Dr. Prashant, we'll get back to you, sir. We'll get back to you. Back to Dr. Mohammed Ismail, please.
Thank you.
Yes, sir. You're on. You're on.
So I finished the
Cheese mute.
in 2 layers, and you can see that I have fixed that I have taken a stitch to the mutton stomach. This is with my experience. Sometimes it is a long tube with connected to the small intestine. I had a patient with the twist of this. The patient had vomiting continuous. So after the investigations, we looked into it, and there was a rotation of the GJ junction. After that, I usually take a stitch from here to the remnant stomach, and on the right should be into the efferent loop. I'm going to do a dye test like this. Make sure that there is no leak. So you can see that there is a long tube, straight. There is no, and the GJ also it is comfortable. There is no need why you should get a bile reflex in this case. Yeah. So
Dr. Ismail, can I?
And see me, especially the corners, whether there is any leak of the dye.
Dr. Ismail, can I ask you a question? Some surgeons like to put an anti-reflux hitch stitch to the loop, so that yeah.
The procedure itself is not HTB. In contrast stenosis, gastric bypass, they have described as you can take this loop and take it like this. But I don't think, you can see here also, I am using this from, we have started the procedure in 2012, and very few patients actually are troubling with the bile reflex or the marginal ulcers. So if you do a proper GJ and a proper procedure, definitely this is a very good procedure. Any more questions?
Well, we have enjoyed seeing your procedure completely. It looks very clean and very nice. And thank you for showing us all this wonderful procedure.
I take this opportunity to thank again and the team, and would like to thank my the team of the audiovisual team, Dr. Mahesh, Dr. Sasidharan, our anesthetist, and all the other members of my team. Thank you very much.
Thank you, Dr. Ismail. A big round of applause to Dr. Ismail, please. We are now going to shift to GEM Hospital.
Back to GEM Hospital.
Yeah. ETP, RS,
Hello.
hernia repair.
Yeah. Can we have the commentary from GEM Hospital, please?
So far, what we did, we created adequate space on the. Now we are doing that reconstruction of the linea alba. Before that, what we did, so we created adequate space on the left retrorector space. Then we divided the medial attachment of the left posterior rector sheet to the linea alba just 3 to 5 millimeter below the linea alba, because the linea alba integrity should be preserved its entire length. Otherwise, if we make multiple holes, then the chances of weakness, because of weakness, the chances of recurrence will be more. So after that, the crossover done in the upper part of the abdomen, where that falciform ligament contains lot of fatty tissues. So injuring to the peritoneum will be less chances. So crossover done usually the biggest region. So I think everybody watched. So now after crossing that linea alba, then when you're dissecting just below the left right posterior sheath, you can see sometimes that brownish discoloration because of that right rectus muscle. So where we'll make the incisions, we will enter the opposite side retrorectus space, will create the same adequate retrorectus space creations. Then we'll divide that right posterior rectal sheath which is attached to the linea alba, will make these two compartment in a single compartment by dividing that posterior rectal sheath which is attached to the linea alba. After deciding to the arcuate line below the arcuate line, because in these cases patients having bilateral inguinal hernia, so we dissected up to the pubic bone. So after the creating adequate space, then we assess the posterior rectus sheath able to close comfortably or not, but is some lower aspect, some tension was there, so we did TOR to release the reduce the tension while suturing the posterior rectus sheath. Then we close the posterior rectus sheath with the 2-0 absorbable bribed sutures, because that is why initially we used PDS, but bribed sutures will keep the approximated edge together, so taking bite will be easier. Once the posterior rectus sheath is closed, then we'll start closing the defect on the linea alba from below upwards. Here we are using the barbed sutures, one Prolin.
In the meantime, we'll have change in the chairpersons. Thank you, Dr. Ravindra Bhate and Dr. M.M. Sarnaik for moderating such a difficult surgeries. I'll request Dr. Mudhare sir to please felicitate our chairpersons. Dr. Ravindra Bhate sir and Dr. Sarnaik sir. In the meantime, I will invite the next set of speakers, Dr. Prashant Lad, an eminent oncosurgeon, Dr. Sagar Kurunkar, our secretary and another eminent oncosurgeon, and Dr. Nikhil Godovni. Please come and have the front seat.
So we have reconstructed the entire, strengthened the entire length of the linea alba with the barbed sutures. So linea alba will always use non-absorbable sutures, one either ethylon or Prolin.
We'll be sticking to time, so in another 5 minutes, the new transmissions would begin. Sharp at 11 o'clock, we'll have a new transmission from Kolhapur Cancer Center. No. And one side, and Ruby Hall on the other side.
So linea alba sutured up to that divided end. So once the defects are closed, then we'll place the Prolin mesh. These are the advantages over the IPOM, because here mesh is placed in between the two physiological layers. So Prolin mesh is enough. These patients with inguinal hernia, initially we are placing the mesh over the myopectoral orifice on both sides. So whenever patients having inguinal hernias and ventral hernias, umbilical, supraumbilical, infraumbilical hernia, if surgeons already doing IPOM plus means he is having good suturing skills, then E-tape is the best choice. The duration of operating time will be the same almost, but we are using the Prolin mesh, the cost effective. Another thing is mesh is placed between the two layers, so it's better incorporated in the parietal wall. That forming that's fibrous tissue also healthy tissues. So that collagen type 1 is more of when comparing to the type 3. So it's a healthy fibrous tissue. So initially that first mesh placed over the left myopectoral orifice. Now this mesh is going to placed over the right myopectoral orifice. Usually we'll place that mesh around the size around 12 into 17 centimeter. Here the mesh is not able to place flatly, so we are dividing the posterior rectus sheath just medial to the linear semilunar rays. This is a tor, lower tor. So whenever you're doing big inguinal scrotal hernias, initially if you do like this, we create a lot of Bogra space. Even if you injure the sac while doing dissecting around the deep ring, you can able to proceed the surgeries comfortably because already we created a lot of Bogra space. So the visibility is won't be compromised. So lower tor done. So here the plane of dissection is above the transverse fascia. So you are able to see the transabdominal muscles means the plane of dissection is above the transverse fascia. So both side prolin is placed to cover the both side myopectoral orifice. Now bigger mesh is placed around 20 into 15 centimeters. Before that, we'll always fix that mesh to the Cooper's ligament. Because here the created space is bigger, so to prevent the migration of the mesh, fixation always important. Whenever the more space, the migration chances will be higher. Usually we'll fix the mesh to the parietal wall to prevent the migration or shrinkage. So transfacial, either you can put transfacial sutures or can fix to the parietal wall with intracorporeal knotting. To bring out the sutures, we'll use that 18 gauge spinal needle. So this is less traumatic to the tissue. Always keep the mesh wrinkle free and flat. I think field should be comparatively bloodless field because that hematoma is the deadliest enemy to the hernia surgery. So patience is more important because the comparing to the IPOM plus, the here is a working space comparatively less. So ETP is cost effective post-operative pain is compared to IPOM plate is very minimal. So patient next day can be discharged comfortably with mild analgesia. So no intraperitoneal exposure. So tissue adhesion formations, erosions, visualizations. In future patient required surgery also, we can do comfort intraperitoneal surgery can be done comfortably. So once mesh placed properly, we'll deflate it. Any doubt, then we'll put the trocar into the intraperitoneally, then we'll check it. Thank you. Any queries?
Sir, thank you very much.
I thank organizing team for giving this opportunity.
Thank you, sir. Right. Go with Dr. Prashant for the time. Oh, no, let's have Ruby on the right side. Ruby on the right side, single screen. Okay, right. No, cheese, mute. Okay, we are going live to Ruby Hall with Dr. Kedar.